shock, seizure, what else?
Trauma.
Sepsis, trauma,
Save you every time.
Septic shock.
that's sepsis, trauma, we had shock already. All right. What was the next question? Or what was the next information I gave you?
What are you gonna do?
So, treatment. All right, so they did the ABCs, EKG showed sinus Brady. You already know the rate. What did I say it was, 26?
26.
Pulse ox. %. Pupils,
What's your CO2?
they didn't do whatchamacallit, capnography. Pupils are small, pinpoint. No response to pain. So what do you want to know?
Nothing bad.
History, meds.
All right, so there's a son there. The EMT got a history. Medic never looked at it. Meds. Those are her meds. Tell me about those meds. What's Cadian? All right, the long-acting, time-released morphine.
Yeah.
What's verapamil? Flowpressor. Xanax. All right, benzodiazepine. Those are her meds. What did the medics do? All right, you got an airway. They put a line in her, monitor. I don't remember if they did a C-spine on her or not. They did pacer,
No. Yeah, pacer.
Yeah.
external pacer.
Yeah.
Yeah, they put an external pacer on her, no capture. It was running, but there was no capture. And they gave her atropine. And what happened when they gave her atropine? Nothing. They gave her epi-drip. What happened with the epi-drip? And they transported her to the hospital. She presents comatose, pinpoint pupils, unresponsive, with an airway in place. Again, I don't remember if it was endotracheal intubation or what they did. With another dose of atropine being given and an epi-drip running and no change in her initial vital signs. I got the run sheet from the EMT and said, are these her meds? He said, yes. I said to the medics, did you see her meds? And the medic said, no. I said, then how can you treat her if you don't know what she's taking? I said, what's this rhythm here? Oh, sinus Brady. some kind of block, complete heart block. So I had 3 or 4 different answers. So what did I look at in this patient besides what they did or clinical presentation? What did I focus on? Meds. What causes pinpoint pupils? There's a couple things. Okay, overdose is a big one when you have that kind of med list, that you have to consider that as a cause. You can usually get it from a pontine infarction, pontine in the brain. Pons is part of the brain structure. You can get it from profound metabolic acidosis. So you have a few things that can cause it. However, as that old adage goes, don't look a gift horse in the mouth. You have the etiology for her problem right here. What do you do with Acadian, long-acting morphine? What can you do for her? Okay. Give her some Narcan. That should reverse it temporarily. Won't last very long, but it should reverse it. According to the son, she was not supposed to be taking this, and he was unaware that she was still using it. What are you going to do with the Xanax? She was not supposed to be on that either. What do you treat Xanax OD with? Romazicon, which I'm sure you don't carry because EMS doesn't carry it, so.
But nothing we carry would.
That's the problem. Because you follow EMS's common treatment guidelines, you can't treat this patient.
Is that Romazicon? Is that what you wrote?
Yeah. No, it's because it's a little crappy. Romazicon is the antidote for any benzo overdose. Versed, Valium, Ativan, Xanax, Restoril, any of the benzos that are out here. It'll reverse it for a short period of time. So the only thing you have that you can use, of course, is Acadian, so you can wake her up. Are you going to affect a change in her heart rate and blood pressure? Probably not. What is the treatment for these 2 drugs? Verapamil, a calcium channel blocker, and Lopressor, a beta blocker. How do you treat calcium channel overdose? All right. Calcium gluconate is preferred, but calcium chloride will work. How do you treat Lopressor or beta blocker overdoses? Right. Glucagon will work. Here's the conundrum. They only last about 40 minutes. It will speed them back up, but you got to give repetitive doses of meds.
How about epi on that?
No, epi does not work. Doesn't work on either one. That's why the atropine and epi they gave didn't do anything. That's not the treatment. Does not work.
I looked up last time we had a discussion of how glucagon actually worked on a beta blocker overdose, and it bypasses what I read was it bypasses the actual beta receptors and goes straight to the receptors that are in the brain.
No, yeah, it may do that. I don't know. I didn't look it up to see how it works. But now the problem is it takes more than 1 milligram of glucagon. How much glucagon do you carry?
One. Well, actually, none.
We don't
Carry
carry
none, but I mean, if we did, it's probably one.
It's high.
Usually it's 1.
Is it expensive?
Not that I'm aware of now. It's been around for years. So it's going to take 2 to 5 milligrams of glucagon, and it's going to take at least 1 amp of calcium, whether it's a gluconate or the chloride. You'll get about 40 minutes of resumption of normal cardiac function until the drugs the patient ingested take back over again, and they metabolize their calcium and glucagon. So you have to keep giving it repetitively. That's what I did. She woke up, heart rate sped up, and the medics came over and said, "What did you do?" I said, "I treated her verapamil and Lopressor overdose." "Oh, but we didn't get a history that she overdosed on it." I said, "What do you think the patient's going to tell you?" He said, "She's in a coma." I said, "You have to look at her meds and assume that there's been some kind of mistake made in what she was taking, or she's sensitive to it more so than usual." So we had our little bedside educational event, and then I went and pulled her old records. 3 weeks prior, and I didn't know this when I saw her, 3 weeks prior She was in the ER with exactly the same thing. Exactly the same. What did they do for her? They intubated her, they put her in the unit, they gave her some fluids and a pressor. Never once did they give her calcium or glucagon. She had exactly the same presentation with almost identical EKGs.
So obviously she came back.
Because nothing was changed. She went out, when she was discharged, she went back to her usual regimen. And according to the son, he said she wasn't supposed to be taking the Cadian, and that she had some dementia and gets confused. She was supposed to be taking the Xanax, but likes to get stoned. I mean, you know, what the hell, she's 72, so what? But because of her dementia, she never remembers how much she's taken or if she's taken the meds, so she takes them repeatedly during the day. And he's found her before where she's been really stoned, but not to this extent. So what happens is she takes these meds, and she doesn't remember that she took them, and she takes them again. And she was on a long-acting verapamil. What is verapamil used for?
It's used for, it can be used for hypertension also.
In terms of its oral dose, it's used for hypertension and sometimes AFib orally. So if a patient's on verapamil, more than likely it's because of hypertension. And in this case, Lopressor for the same reason, probably for hypertension. Okay, so she was on meds to treat an ongoing medical issue. The problem was that she being demented, doesn't remember if she took her meds, and number two, was already in with this. They discussed the pacemaker, didn't do that because in the course of 24 hours, this went away because obviously the drug's been metabolized now, and she was back to her usual self. So again, another example of not thinking and reading what you have sitting there, and this is what you end up with, an iatrogenic situation where you create a problem because you're not paying attention to what the patient has. All right, let's take a break while I work on this thing. Do the majority of the work. Because why? Well, they have residents. For one thing, they have a big budget. They're all integrated systems. They're all fire EMS. They're not separate systems. So let's look at some of this stuff. This is one of the medics that actually works for Denver Health. Okay, so here's a myth. Pain management is bad. Treating kids with pain medicine is not good. I'm sure you've heard that occasionally, going into an ER. If you talk to pediatric emergency physicians, they'll tell you that kids need to be medicated for pain. So this myth, of course, is inappropriate. Standard medicine that we use for pain is morphine, and we use 0.1 milligram per kilo. Okay? Now, you can give that sub-Q or IM. Most pediatricians, that's what they prefer. I use ketamine because what we usually are after is to do a procedure on a kid to either get blood or an IV, but we will talk a little bit about that too. There's another series in here on ketamine use. So you have William Osler, one of the great physicians and writers. He was a great observer. All your textbooks in medicine and anatomy talk about him, or his principles that he found during his lifetime. And he says, care more for the individual patient than for the special features of the disease. What do we talk about all the time? Look at the patient. Even your first lecture today on bradycardia, what was it about? Look at the patient, not just at the monitor or your pulse ox or your blood pressure reading. Look at the patient. Does he fit what your other diagnostic abilities are telling you, or does he not fit that parameter of what something is saying? You see that a lot with pulse oximetry. You really got to be careful. Pain myths. And you'll hear this if you haven't already. A lot of the ER doctors may say, oh, you don't have to treat him. It said it can wait. No, that it can't. You know from being down in Bonita, you might have a 20-minute transport time to a hospital. Now, you're further than that from Health Park. You need to go to Health Park. I know North Collier's not that far away, and they take care of kids there. But the point is that you don't want these children suffering, and why? Because the biggest issue is an increase in their morbidity later on in their care. If you want to look at an article about it, you can look at the one from Abdul et al. It says pre-hospital emergency care in 2003. The doses started in the field, as written by Vesalitis from Emergency Medicine 2002. Yeah, okay, we tend to give a little more. I do give more medicine in ER to a kid. I will give them 4 to 5 milligrams per kilo of ketamine when it's really 1 to 2 or 2 to 3. I will give them a higher dose. If they're in the ER, I can monitor them. You monitor their airway, and that's all you need to do. Remember, we talk about kids and respiratory or cardiac arrest. In children, it's usually a respiratory arrest. So you really have to be cognizant of the fact that their airway is important. If you're having a problem with them, it's got to be the airway that's more than likely involved. It isn't safe. Well, all pain medicine can cause hypotension and respiratory depression, but of course it's dose dependent. Morphine, believe it or not, has a very large efficacy and safety range. Very easy drug to use. Now, I know we don't use it anymore because EMS in their infinite wisdom felt that fentanyl was a better choice. And now you can't use fentanyl because the ER doctors in Lee County say the patient is coming in too sedated and they can't assess it. So, they're going to what? Toradol. So let's induce renal failure in patients instead. Can we manage respiratory depression and hypotension in a patient?
Well, total alcoholism is that? So why do they give us so much for kidney stones?
You have to use very small doses, and you have to be careful. I don't use it at all. I use it occasionally. The elderly get a much greater problem with acute tubular necrosis from it because it is related to the non-steroidals. And we know that non-steroidals, particularly Motrin, does cause renal failure.
Doesn't total have some aspirin?
Well, yeah, those are non-steroidals.
Right.
And that's what induces a renal failure. They get acute tubular necrosis, and the actual tubules in the kidneys die. So again, looking at some of the people that have written this, and notice these are all in usually pediatric kinds of journals, but it says that you can pull these up and look at them, keep them in your library bank of information. And they go through the different medications and doses and what you have to be aware of. But it's things that we already know. There's one thing in here that I'm going to mention when it's towards the end. And it's about kids, and this old statement that's been around for decades. Kids aren't little adults, and in fact, yes they are, because their physiology and anatomy is the same as ours, just it's on a different scale. That's all you have to remember because of their weight. But they are little adults. So yes, you do treat them almost the same as you do an adult in many instances. Pain management, again, abdominal pain. Now, you know you've gotten into this with the ERs multiple times with patients with belly pain, trauma patients with pain, and they give you a hard time because you medicate. Now they say, oh, I can't assess the abdomen. And as I told you before, that's bull. Yes, you can assess the abdomen. Number one, I don't know any ER doctor in any ER in any part of this country that doesn't CAT scan every belly that comes into that ER. Every single one. So in terms of assessing it, he never even touches the patient. Surgeons, same thing. You call a surgeon for a patient that comes in belly pain, first thing he's going to ask you is, did you get a CAT scan? Even if it's a guy who's 27 years old and you know has appendicitis, he's going to say, did you get a CAT scan? Well, no, he's a 27-year-old male with appendicitis, a negative urine, an elevated white count with a shift. He's got appendicitis. Well, get a CAT scan. Well, what else is he going to have? So, I say to you, medicate him. give them something for pain. If the ER doc gives you a hard time, say, hey, you're gonna do a CAT scan on them anyway. Or you can say, hey, my medical director says it's fine to medicate abdominal pain. You have a problem with it, take it up with him. Here's the articles you can quote, which none of them would have read, so they don't know what you're talking about. Trauma patients, there's a new, and I think Saria in the article that's referenced here, I think that's where they talk about ketamine use in trauma patients. Because it causes that dissociative anesthesia, and they won't have pain, and you can do what you need to do with them. I think it's in there in the Journal of Trauma.
That's all the military uses too.
Yeah.
Where do we plan on carrying that, sir?
EMS in their infinite wisdom has not supported it at the medical care conference level where we go with new ideas and meds and drugs and stuff.
That's
Because the ER doctors are afraid of it.
Well, when we have room, we usually be here.
I can't make protocols unless the agency says I can follow the common treatment guidelines.
So we need to have our own protocol.
If we had our own protocol, we can add to the common treatment guidelines. See, the whole purpose of having this medical care committee and protocol committee is to make everything standardized across the county. The problem that you have with that is that EMS wants to run the show, and they don't permit, because they have more votes, they don't permit any deviation from very simple guidelines. Because their medical director is concerned about being sued. And all he wants to do is make it so that you can't really give much of anything, so if something happens to a patient, you can't be sued because you gave the medication, and maybe that's what caused it.
So how come we're able to inundate it right now?
Because I allow you to do that.
Can we do it right now?
Yeah, we can do it all, but see, you get into this where now you have two different sets of protocols. And that becomes a problem. Because an EMS who's still in this area and still responds to our calls, their protocols will be different. And your protocol, you're using all these meds and things that, I espouse should be part of your armamentarium, and they're not allowed to use any of them. So what happens is you will need to go on every transport with them to the hospital, because they don't know anything about these drugs.
So this is basically because we don't transport.
Yeah.
Like if we would,
In transported, we could do anything we wanted. We could have our own set of protocols, because you're just dealing with you, the patient, and me. You're answering to me with the protocols, you're not answering to Lieutenant EMS.
Yeah, 'cause they've always carried like succinylcholine or something like that, and we never carried before.
They have nothing now. They're not allowed to intubate, they're not allowed to RSI patients.
total.
They have total buckets of it.
Yeah, well, you know what's gonna happen, they're gonna have cases of renal failure, and somebody in their infinite wisdom knew so much that switched it to Toradol. Why they ever took away morphine is still beyond me. And, it's fine listening to the community ER physicians, and you wanna talk with them, that's fine, but you know what, they don't dictate protocol. They don't dictate guidelines in the pre-hospital setting, because none of them have any experience in it, so. Okay, so as I said, yes to abdominal pain and trauma patients. You will see, I'm hoping in 2 years, ketamine used more widely. When you get over the initial fear from the medical community about ketamine, it comes from a lack of their understanding. Just screaming kids here. That kid is telling you what he thinks of having to suffer in pain before he,
Is that my kid?
could be. Okay, so let's look at a couple of different things that they use here. Now, we don't have, you see that little hat thing on the end of the syringe? Yeah. They use that in the ERs. Oh, do you carry them?
Yes, I know.
Okay. Do you use fentanyl nasally?
Are we okay for
We carry them.
Oh, well, then I guess you can.
Well, the medics
It was
do.
for the morphine.
The EMS.
You can use that for Versed, and
Yes,
it can be used for a lot of
Do
things.
that in case you get, if they have a seizure instead of giving it.
Yeah. So fentanyl's 2 to 4 mics per kilo, 1 cc a nostril. Versed is midazolam, it's 0.2 to 0.4 milligrams per kilo. Now, I want to say one thing about intranasal med use. We really don't know how much of that is absorbed through the mucous membranes and how much is swallowed. Because that's what happens to it. You can put a cc up your own nose, you're going to swallow most of it. So how much of that is actually absorbed through the nose and how much is swallowed, who knows? We know it works, we know the onset of action is a little bit longer than if you gave it IV. But as a rule of thumb, it does take a little bit more for intranasal use. Myth number 2, children don't get C-spine injuries. That's why we don't carry C-spine collars for kids. Okay, well, that's not true. Because of the ligamentous attachment and the way C1 and C3 sit around the axis, you know, the odontoid, that's a fulcrum. That lets you flex back and forth. And kids, their ligaments are very lax. So that really can flex back and forth, and you can fracture the vertebrae or the spinous process or even the transverse processes. So you have to have that as a consideration. Younger than 8 years old, they have a little greater incidence of fractures in their neck. And how do we get that up there? I don't know. I'm probably going to lose some of this picture, but let me just see. We can just pull that up a little bit.
Can you go over everything we missed?
No, I'm going to test you on that particular part, too.
No problem.
Okay, so let's just look at the difference between necks. We're just going over 10 myths of the pediatric population that's commonly espoused in the emergency medicine practice literature. Okay, so adult C-spine. See, you have your normal curve. It's a little bit stretched out, but these all should line up pretty much. All these spaces should line up, okay? Now, you see in the kid, now, you get frequently, this is called a pseudo-subluxation in kids because their facets are different. The facets are the little openings on the side where the bones touch each other, so that you're going to get a little more motion there. In addition, the ligaments are a little more lax because they're still young, and the vertebrae, the shape of the vertebrae is a little bit different, okay? The soft tissue isn't as thick and heavy and muscular as in an adult, so it doesn't hold the spine as well. So you're going to get some changes anatomically that are normal when you look at a neck in a normal kid who hasn't any trauma, and those would be exacerbated in somebody that has that trauma. Right now, I know we talked about CTs months ago, but right now there is a really strong push on not CTing kids with injuries. So they don't want to do head injuries, they don't want to do belly pain, they really frown on it unless they've been seen by a pediatric emergency specialist or a pediatrician. So, you mentioned some of the issues with C-spines. Immature ligaments, the bones aren't really hardened yet. Vertebrae are a little bit more wedged than an adult. They haven't really gotten square shaped. There's soft tissue that does not have much support to it. The predental space, you know what that means? Space between the dens and the vertebral body. C2 and C1. You look at that space in an adult, and if it's greater than 5 millimeters, it suggests a fracture. However, in this day and age, nobody looks at C-spine films on anybody. They all get CAT scans. This is something that, again, you're not really going to see this per se, or you may not know it per se, but this is SCORA. It means spinal cord injury without radiographic abnormalities. First reported in 1983. So in other words, because of the same principles we saw in the previous slide, you can have the same kind of injury and not be able to see it on standard x-rays. It comes from a rapid decelerative force, and if you look here, you see some bending in of the spinal cord. That's what this is. These are the vertebrae. This is an MRI scan, because you won't see this on a CAT scan. Okay, MRI scan. This is a spinal cord, and they're just showing you where there's some little bit of indentation